Thanks to Dr. Unni, Dr. Manoj, and the third gentleman who is on his way here. Every time I get an invite from RIC, I break into cold sweat. First of all, you cannot understand the title of the talk. It takes about 2 weeks for you to understand the title of the talk. And then you're supposed to prepare for that. So I kind of broke it into little pieces, and I decided to take it the easy way. So when a patient walks in with CSR into my clinic, what I would do is what I decided I will do. So sticking my neck out, lamb to slaughter, and let's see what we do. Easier done is like, I don't do micropulse, so I'm not going to talk about micropulse. I'm sure the panel here will help me out with this. Let's look at 6 clinical situations in the next 5 minutes and what I would be doing. So the 30-year-old patient who is an IT professional comes with decreased vision. What he has obviously is a central serous retinopathy. So one investigation which I do in all the patients with central serous retinopathy now is the OCT. It does give the OCT as well as the color photograph. So how does it help? It may tell us where it is leaking from. There could be a subfoveal PED. Then you know that this patient is not fit enough for laser photocoagulation. But then instead of calling the patient about a month or 6 weeks later, I would call them probably a couple of weeks later. So you see the fluid going down, then you know that this patient is going to do well. The fluid is not going down or getting worse, then there's no need to wait. We can probably intervene earlier. So OCT does help us to show if the patient is going to get better or not. So another patient who is 35-year-old, but then instead of the fluid going down, the fluid increased. So what would I do next? Autofluorescence is something which I do once again in all the patients because it doesn't cost anything. It's not inconvenient to the patient. So whenever all the OCT machines do have it, so whenever you do a OCT, you do take an autofluorescence image. Autofluorescence can show us where it is leaking from. It's a hypoautofluorescent spot. But then is it good enough to treat? Probably not, because here you see 3 different areas of hypoautofluorescence. You don't know which is leaking. So in a patient where the CSR is not resolving, next step is to do go back to your old wife, fundus fluorescein angiogram, which will show where it is leaking from, and if it is something which is amenable to laser photocoagulation. Here, of course, it is away from the fovea. You can very well do laser photocoagulation, and that's what we did, and patient got better. Then here is a 40-year-old patient with CSC, and possibly more than 6 weeks, and you guys see something like shaggy photoreceptors. So here what we can do is to differentiate between acute CSC and chronic CSC, the autofluorescence helps. So we can see these tracks, hypoautofluorescent and hyperautofluorescence you can see. So autofluorescence does help to differentiate if this patient may have had previous episodes of CSC. And in these patients, I would do an FFA and an ICG. Here we can see a subfoveal leak. This is the FFA and like it shows a subfoveal leak. So patient underwent, because the lesion was under the fovea, had to undergo laser photocoagulation. So in a chronic CSC or a subfoveal leak, I would do an FFA and an ICG, in addition to, of course, an OCT. The ICG tells us which area we will treat. The area of hyperpermeability I would treat, not only the area of the leakage. So before I do PDT, we'll look at the autofluorescence image to see if there is areas of RP atrophy. So these areas of RP atrophy, we may want to be a little bit careful, particularly in chronic CSC, in doing PDT, where the RP atrophy may worsen or whether we'll be causing iatrogenic decrease in vision. But it's a little controversial issue. But then patient who has been having multiple attacks, we may want to be careful in doing a PDT in these patients. Here is a 60-year-old patient who presents with CSC. So this is an atypical presentation. A 60-year-old patient usually doesn't present with CSC, but then of course, then what you would need to do in a patient who is presenting atypically is to do all the investigations, FFA and an ICG. And this patient did undergo ICG and found out that patient had a PC which was mimicking like CSC. So this is something which you would want to rule out. So atypical presentation is another indication where you would want to do both types of angiogram. Here's a 5th situation. A 46-year-old underwent photodynamic therapy for CSC. So nowadays what I look for is the presence of pachychoroid. So if there is a pachychoroid, whenever I image this patient on OCT, I would do an OCTA as well. So if I do an OCTA, yes, Dr. Mahesh was fighting with Dr. Srinivas Joshi about this to see if there is a pachychoroid neovasculopathy. Any patient with pachychoroid, an octa will be done. So in this situation, in these last two situations, that is PCV and chronic CSC with CNVM, where you don't know what is leaking, what is causing the fluid, is when I would use anti-VEGF. So this is how the treatment varies based on what the investigations I do. The last situation, a 55-year-old gentleman presented with central serous retinopathy diagnosed elsewhere, had a little bit of fluid, and when he came back, about a month later, the fluid had increased. So I put the patient on eplerenone, and following which, 2 weeks later, the fluid decreased. So eplerenone has been used in acute CSC, chronic CSC with bullous RD. Currently, I use it in resistant cases, but still it's not clear when you would use mineralocorticoid antagonists. There are a couple of recent articles which show that like when you can use and when it will work. If you do octa and ICG, the ICG shows hot spots. These patients respond to eplerenone. In contrast, if there is a CNVM, the eplerenone doesn't work. And again, the last one is the ODR, that is the optical density ratio. So compare the optical density ratio of the vitreous between the subretinal fluid with the vitreous. If the optical density ratio is lesser, these patients tend to respond better to eplerenone in contrast to those who don't. So to summarize, FFA to tell us if laser photocoagulation will work or not, or whether it's required or not. ICG to tell us whether the patient will respond to PDT, anti-VEGF or MR antagonists, octa, PDT or anti-VEGF which to be used, FFA, PDT yes or no, sorry, FAF, that is autofluorescence, that is a kind of relative indication. And I'm sure this is going to be the response to my talk. Like a flea-laden dog, I'm sure RIC is not going to have me here next time. Thank you very much.